the time it's a virus. Most often it's a virus. Now it can be bacterial. Fungal is also there, can be rare, but it might not even be infectious. It could be allergies or GERD or dry air, the weather. So let's look at this picture. It's inflammation of these sinuses. Of course, we have all the sinus cavities. Most often, you're going to see frontal and maxillary infected. When they come in and you're doing your assessment, they're going to be tender in the frontal and the maxillary sinuses. And they're going to say, I've had a ton of thick, copious, purulent drainage. My head feels like it's a swollen balloon. I've got pressure here. When I bend over to tie my shoe, it hurts. My teeth or my jaw hurt. They can also have nonspecific symptoms, fever, cough, URI. Regardless of the pathogen, they're going to tell you that. All right, I told you you're going to have swelling here. If you did transillumination, there may be opacity within those sinuses. So how are you going to know when to treat or what to treat or how to treat? Regardless of the cause, and especially in acute viral rhinosinusitis, which is our common cold, you want to provide symptom management. So how do we do that? Saline irrigation. I do telemed, right? I have it here as my prop to show them. Get some saline, lean over the sink, you squeeze it, you squeeze it, you squeeze it till it's draining out. Then you blow it all out. Get that mucus out of there. After that, you know what I tell them? You get your Flonase, your fluticasone, your whatever your Flonase steroid of choice is, Rhinocort, Nasacort. You do opposite hand, opposite nostril. You point it back more into the sinus cavities, not into the septum. You're going to do the sprays and you're not going to inhale deeply. If you inhale deeply, it's going straight down the back of that throat. Now, this says it may have benefit, especially if they have a history of allergic rhinitis. I'm telling you, it is great benefit, okay? And the guidelines say, yes, you can use it. Now, these other things, if it's really thick, maybe they need some guaifenesin to thin it out so they can blow it out and spit it up. Antihistamines, this is like that catch-22. If they have a lot of allergies, maybe, but sometimes it can cause it to dry like a cement brick in their head. And then you don't want to do that because then it's really going to settle into maybe a secondary bacterial infection. Decongestant, Sudafed, sometimes that can help. Same kind of concept with the antihistamines. Maybe if there's some eustachian tube dysfunction, but don't overuse those. So no matter the cause, you're going to do symptom management. But let's figure out when we're going to give antibiotics. Which of the following presentations are most consistent with a bacterial sinusitis? Facial pain and congestion lasting more than 10 days. Symptoms are most severe on days 3 to 6. Congestion and pain are severe on days 1 to 4. Symptoms are improving, then suddenly become severe again, or nasal discharge is green and blood tinged. I don't know how many times patients come in and say, my sputum's green, my nasal discharge is green, I need an antibiotic. And I say, you know what? You definitely have an infection, but that doesn't mean that you have a bacterial infection. That could be dead cells. Green doesn't always mean bacterial. What do the guidelines say? The best answers here are 1, 3, and 4. So there's 3 indications that say, okay, we're going to treat this as a bacterial sinusitis. Let me show you on the next slide. It's number 1. The symptoms have lasted more than 10 days. The patient says, I've tried all this stuff. I've done the Flonase. I've done the irrigation. I've given it time. And I'm in pain. My head's crazy. I've got postnasal drip. It's miserable. 10 days, give them an antibiotic. If it's severe, that like from day 1 they have fever and they're crying, so severe with fever for 3 days, okay, give them an antibiotic. Or it's what we call double syncing. They have a URI, they get better, and then they'll say, it hit me like a ton of bricks. And then it was that severe purulent drainage, facial pain, etc. That is what the guidelines say when you suspect a bacterial sinusitis. And we really shouldn't be given antibiotics unless they meet those guidelines. Now, you're going to be a good antibiotic steward and it's hard, but I'll tell my patients, hey, you know what, if you're not better with these steroids, please come back. Now we know that most often the pathogens here up many times are caused by strep, right? We've talked about how strep is a bad bug. And so if you really are worried about a bacterial sinusitis, you're going to treat that because you don't want periorbital cellulitis or meningitis. But it could also be H. flu or M. catarrhalis as well. Now, what do the guidelines say? What is the management? So it's going to be a beta-lactam. Now, if your patient has no risk for any sort of resistance at all, they haven't been on an antibiotic in 10 years, etc., they're healthy, you can choose amoxicillin. I will say, excuse me, the guidelines are moving closer and closer towards augmentin, especially in children. But beta-lactam, amoxicillin, augmentin, if they've, recently been on antibiotics or they have a history of chronic sinusitis or something different, you may consider even high-dose augmentin. All right, and if they have a penicillin allergy, doxycycline is a good second choice, or maybe a third-generation cephalosporin. Now, the duration. I think Jennifer was talking about how, everything was 10 to 14 days, 10 to 14 days. And as a practicing clinician, there are some things that it's just hard to change. This was one of the things that has been the hardest for me to change because everybody gets 10 days. But guess what? That's not what the guidelines say. The guidelines really say 5 to 7 days is enough. Now, we never say never, and there are those patients that may need longer. But in general, you need to really back that down to 5 to 7 days, okay? A patient complains of sneezing, postnasal drip, and nasal congestion. Considering the most likely diagnosis, what other findings does the NP expect? So what do you think this is? Sneezing, anytime you see sneezing, postnasal drip, congestion, I'm thinking allergies, allergic rhinitis. So what are we going to see with allergic rhinitis? Number 2, boggy gray nasal turbulence. Number 1, that's more consistent with an acute bacterial or acute, maybe not bacterial, but an acute rhinosinusitis. Now, number 3 is also true. Have you guys seen it on the posterior pharynx? It really does look like cobblestoning or like a brick pattern, and it's from that irritation of all that drainage going down, frequent throat clearing, the irritation. So when you see that with the whole picture, you're thinking, all right. Now, the tenderness, that's more with an acute sinusitis, but those swollen, boggy nasal mucosa turbinates, you're thinking allergies. And man, patients are miserable when they have allergies, right? They're watering, they're sneezing, they're dripping. I have allergies, it's annoying. There was a period when it was just way out of control, and I said, I feel like an old lady. I mean, they always have the tissue, right? Because they're always dabbing their eyes, blowing the nose. So look for that. They have the tissue stuck, and you're thinking, all right. Sometimes in kids, you'll see what's called an allergic salute because they're rubbing their nose like this, and they'll see a little line here, or allergic shiners where you get the edema and the kind of darkening color around the eyes. Now, how do we treat allergies? And it's not what you think. What do people go to all the time? Because it's over the counter, it's easy. Everybody's on Zyrtec, Claritin, Allegra. And those can be used, but you know what the guidelines say? First line are intranasal glucocorticoids. First line. So there's better relief. These prevent the allergens. They're most effective. It's beautiful at all the symptoms. Eye symptoms, drainage, sneezing. So first line, really get your patients on the intranasal and tell them how to do it correctly so that it will really work. Now, you can consider these second generations. One note, they all are saying non-drowsy, right? Second generations are non-drowsy, but no, cetirizine absolutely is the one that causes the most sedation. So if you prescribe that, have them take it at night. This is just a funny side note. I figured this out in NP school that when I would take cetirizine, I kind of felt a little, ugh. So, when I took mine before my Oskies, okay, this is off label. This is not a commercial for it. I'm just saying it does cause sedation. And then what have gone over the counter recently? Astropro, yes. So that's something that you could consider, and you can do those in combination with the steroids. But for your test and for best practice, first line are your intranasal steroids. Now, decongestants. You know, pseudoephedrine, that can be abused. We know that in athletes, and you can make meth. I mean, none of us are probably trying to do that. But it does have that abuse. And so we want to be careful not only because of that, but also because of the side effects. Hypertension, thank goodness we don't use MAOI as much because they had way too many interactions. But if for whatever reason your patient was still on that, definitely contraindication. And then these other conditions here. And we've talked about all of these, but just be careful with decongestants in these conditions. Okay? Epistaxis. So, of course, we think nose bleeding, but honestly, it's bleeding from anywhere in the nasal cavity, the nasopharynx, and it usually comes out the nose. So, this can be anterior or posterior. Most of them are anterior. 90% are anterior. Most are anterior. I don't know if I think I said that wrong. Most are anterior, 90%. And that's from irritation in the Kilbessex plexus. Kesselbach's plexus, all right? Now, if it's posterior, those are the ones that involve our larger arteries, and these can be life-threatening. Have any of you seen anyone bleed to death from one of these? I have, and it was a bloody mess, and it was horrible. So you've got to make sure that you're aware what kind of bleeding this is, and how are you going to know? Sometimes it can be minor or severe. Anything that's severe and you're worried about posterior bleeding, they've got to go. But let's talk about kind of the characteristics. Who do we see this in? The fancy word, epistaxis digitorum. I love that. In kids, of course, they're always picking their nose, sticking stuff up the nose, and some adults too. Um, but that is a frequent cause. Sometimes we don't know. Sometimes it just bleeds. Sometimes it's dry in the winter, high blood pressure. If someone's snorting cocaine and, changing all their nasal cavity structures, that can do it. And alcohol, we know, works as a blood thinner. So there can be a lot of causes. We see it more in children and then in the elderly. But anything with an asterisk there, those are patients that you would really be making sure and asking the questions, am I worried about a posterior bleed? Because like I said, those can be life-threatening. So you always want to assess hemodynamic stability, and we know that. We do that in our ABCs first off, right? If you need to call 911 because you think it is, this posterior bleed, they're on anticoagulants and it's just out of control, surely they would have gone to the ER, but you will be shocked what comes to your clinic. So call 911. Now, at home or in the office, most people have already tried, the standard, okay, I'm going to clench my nose. And that's what we want to do. We want to lean it forward, holding that nose 10 minutes, and don't let up. Really hold it. They may try things like Afrin, not the oxymetazoline. Now, I have to tell you two stories about nosebleeds. Number one, I had a patient, she came into urgent care. She was our sweet housekeeper, and no chronic disease, no history. She had been bleeding. It was winter. But, I told her, hey, you might try some Afrin C. I get an alert in my EMR. Your patient has been admitted to the ER. It was from the Afrin. What did she have? It sent her into AFib, and you'll see this as this can happen. So if for whatever reason your patient has AFib or a lot of arrhythmias, don't recommend that. Now, silver nitrate sticks, we use those in burn. Ooh, and they will cauterize. They're painful, but they can buy you some time if you need to, or if you feel comfortable trying that. If you're to the point of cautery and nasal packing, this may be like you're just trying to do your best to make it, depending on if you're in a rural area, you're trying to tamponade to get them somewhere further. And I'm talking about like the Rhino Rockets, nasal tampons. You guys know about that. If it's severe, 911 to the ER. If they keep having recurrent ones, you may need to send them to ENT. This is a fun story. I just like to share it. So I logged in. I can see my chief complaints before I see my patients online. And it said 93-year-old nosebleed. And I was thinking, all right. So we started, she's the sweetest thing. She's telling me, and and she's holding her nose. She's doing it right. Her daughter's there with her. But as we go, I'm like, this is, I'm like, have you had this before? And she said, oh yeah, I was in the ER 2 weeks ago and they had to cauterize it, but it's bleeding again. And she said, I've been holding it. And then she holds up this glass like a juice glass full of blood. And I just said, whoop, stop right there. Stop right there. And y'all are going to the ER right now. The daughter said, yeah, we're 2 blocks away. I can drive her. Okay. So there are times, and this is on your test questions too, there are times that you just stop right there and do 911. So if that's the case, just go for it. Now, the throat and the tonsils. Oh my goodness, people always, they wake up sore throat, they call you, I want an antibiotic because I have what? They all think they have strep. But look, 50 to 80%, it's a viral, a cold. I mean, you can have mono and Epstein-Barr, that is mono, cytomega, cytomel, like my words are not working anymore, CMV, HIV, but less common is really the strep. And then remember the non-infectious irritants that we've already talked about. So look, group A, hemolytic strep, only 5 to 15% of the time. And you see that throat and you're like, whoo, I can smell it from here, right? And that is a bad, nasty throat, and I'm sure that patient's miserable. But just remember that only 5 to 15% of the time is it truly strep. Now, if it is, we're gonna treat it because we're worried about complications, but very low. So let's talk all about strep. The NP has diagnosed a patient with pharyngitis and suspects infection with group A strep. What complications would occur if strep throat is not adequately treated? All right, so we're treating strep to prevent complications. What are the complications we're worried about? Number one, periorbital cellulitis, not so much. Down here, up here, not so much. Rheumatic fever, yes, we talked about that yesterday in antibiotics. A bad bug can affect the heart. Acute glomerulonephritis, yes. Peritonsillar abscess, ooh, have you guys seen that? That can be scary and life-threatening if it occludes that airway. So yes, epiglottitis, yes, we're going to talk about that later, but strep can cause epiglottitis. And then we all know that it can cause scarlet fever. So we treat strep for the sequelae of strep, okay? And let me just say this right now. How many days are you going to prescribe your penicillin or amoxicillin for? 10. Do not prescribe 7. All the data says if you're going to prevent the sequelae, they need 10 days. 10 days. First line, penicillin, amoxicillin. Okay, and penicillin's really a little bit higher up. Now, how do we know who to swab, who to treat? You know, what are we going to do? So, because patients all think they have strep, right? So Centaur criteria is a tool that we use to say, hey, it's statistical probability based on their signs and symptoms. What is the likelihood that they have strep throat? Validated tool. So you say, there's things you're going to ask them. Do you have a fever? If they have a fever, they get a point. Do you have tonsillar exudate or swelling like that picture? Yes, they get a point. Do they have enlarged anterior cervical lymph nodes? Yes, they get a point. Do they have an absence of cough? So they're not coughing. Then they get a point. That's 4 right there. And then this modified, it used to just be that. Then they added on and said, you know what, we're going to add age as a modifier risk as well. We know we see risk more prevalent in the kids. So if it's their 3 to 14, they're going to get a point. 15 to 44, that's kind of hit or miss, so negative. We're not going to give them a point. We're not going to take one away. We know it's more rare with increased age, so if they're over 45, we're going to take away a point. All right, it's not that hard once you do it a lot. So you add that together, whatever your score is going to say, hey, we need to test this patient, or we could even empirically treat. But the score of 2 says, I'm going to do a rapid strep. Score of 3 or more, okay, sorry, 2 says you're going to consider it. Consider it. What is the clinical correlation? But 3 or more, yes, you definitely need to do it. So let's practice with some patients. A 13-year-old has fever, enlarged posterior cervical lymph nodes. Posterior, not anterior. Posterior is more consistent with what? Mono. Okay, so they didn't get a point for that. Tonsillar exudate. And what is their age? 13. So their score is 3. Are we going to swab them? You bet. We sure are. All right, what about this patient? 60-year-old daycare worker tonsillar exudate, temperature of 101.2, swollen anterior lymph nodes. But look, she's 60, so I had to take one away. But you're always, 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 always going to use your clinical judgment, clinical correlation. She's a daycare worker. She's around those little kids that love to share their germs. So am I going to swab her? Yeah. A 25-year-old with a cough and a temperature of 99.4. All right. So she's not in the age. Temperature, technically I think it says over 100.4, but her score is low. So do we need to swab her? Not really. Now I know you guys are all going to say, my goodness, we swab everyone that comes in. And in practice, is that what happens? They come in with URI, they get COVID, strep, flu, RSV, blah, blah, blah. We really should use Centaur criteria and swab if we really are thinking this is strep. But I know you all have the stories. So this is what the guidelines say on who you should swab for strep. So when you swab them, you're doing a POC rapid antigen testing, right? That's the in-the-office test. And most of these can be pretty sensitive. I mean, 70 to 90% of the time. Sensitive, and 90 to 100% specific. So we use these. You should really know. Different kids have different levels of effectiveness or sensitivity, if you will. And so check yours. Make sure that you have a good product. Now, throat culture. We talked about this some yesterday in antibiotics when you would culture. If you had a negative rapid, but you were really highly suspicious, get the culture. Look at the sensitivity and specificity. And then there are times when, recurrent throat infections, different things. Not routinely do you have to do the culture, okay? But when you're suspicious for a negative, especially in your kiddos, there's an indication for a culture. But remember, both tests, it doesn't matter which one it is, it's only going to be as good as your sample. So, if, my goodness, if they're swabbing like the anterior mouth, not a good sample. Really encourage your nurse to get back there, okay? So, and I already spoiled this. 10 days, right? 10 days, we talked about penicillin, amoxicillin. Now, remember yesterday, baby in the bathwater? You can give a cephalosporin if their reaction to penicillin was not anaphylaxis or hives, all right? Macrolide's another indication when I told you a lot of allergies. You can do that. There is some resistance with strep, and we talked about that. Your lincosamides, remember I told you maybe complicated infections here or allergies. You can consider Clinda as well, but remember the black box warning there. Document, educate on probiotics. All right. The NP sees a patient arrive to the clinic complaining of severe sore throat. The NP noticed the patient is sitting in a tripod position, not breathing, having a hoarse, and this doesn't say it, but they may be drooling. What are you going to do? Okay, the first thing you want to do is you want to examine that patient, and then very, very quickly, what is the next thing you're going to do? You're going to get them to the ER, probably calling 911 because we're worried about an airway. Now, are you going to put them in a room to prevent spread of infection? You're going to put them in a room, but you're going to put them in there to examine them. You're not going to have them drive to the ER because this is an airway issue. And then masks and eye protection. Of course, we've all started doing that more frequently, even in, today clinics or urgent cares. But do you have to? No. The best answer here is you're worried about what? Epiglottitis. You need to look and evaluate very quickly so you can decide to get them to the ER. So most epiglottitis, I told you we were going to talk about it. These patients are scary because they can lose their airway, and we know what happens when that happens, right? So these patients are just, they do look like they have the Kleenex box, they have their cup with their spit in it, they can't talk, it sounds crazy. Those are warning signs. Now, we know that epiglottitis used to be most often caused by hip, but thank goodness, due to vaccinations, that's definitely decreased. It still can be a cause, especially in someone that's unvaccinated or elderly and didn't get that vaccine. So that's another point here. You'll hear it in the pediatric lecture, but make sure you're checking vaccination status on your patients. Are you vaccinated? Are we concerned about that? But strep can also cause this as well. On the x-ray, it's going to be a thumb sign. And these patients require emergent transfer because you want to protect the airway. All right. A college student who has been feeling ill for 3 days tests positive for mono. What symptoms is this patient most likely to report? So, anorexia, sore throat, low-grade fever, or anterior lymph node swelling. Well, I told you it's normally posterior, but they're going to complain of a sore throat and usually a fever. All right, so the best answers here are 2 and 3, but let's go through mono a little bit. So their presentation is 3 F's and an L. Not really an F because pharyngitis is a PH, but it's fever, pharyngitis, fatigue, and lymphadenopathy, and it's usually posterior. Now, some can have splenomegaly, but that's usually about half, and we know that this is caused by the Epstein-Barr virus. All right, how are you going to test for it? You all know about monospot in your clinic point of care testing. This detects the heterophil antibodies. It's okay, but you know what? You can get a false negative because you might not have that antibody production within those first 2 weeks. So, can be used, but honestly, if you really need to know or you're certain that you want to know, it's best to get the viral capsid antigen. And we talked about this in GI, IgM, IgG. This is when I see those patients and I say, well, good news. You don't have mono, your IgM was negative, but you had it in the past. Did you know that? Because their IgG was positive. If they got it and it's gone, their IgG was positive, it's going to stay positive for life. Their IgM, the minute they get it, they're miserable. That is their acute infection. These are a little more expensive, usually require a send out, but more sensitive and specific for mono testing. Okay, a patient presents with intermittent pain in the left jaw and cheek for the past week. What diagnosis would you include? And we've talked about these, some through neuro, and well, we're talking about it now. So what did we talk about in neuro? Yes, trigeminal neuralgia, absolutely. TMJ, of course. Jaw, cheek, the joint, makes sense. Acute rhinosinusitis, what did I tell you? Oh, they'll say, man, my face, my jaw, it hurts. So yes. And then dental infections, clearly. You'll see a lot of people coming in for, dental oral infections as well. And any of those could be a presentation, jaw, neck, cheek pain. All right, and you would treat them accordingly. All right, let's move on to the ear. So the ear is beautiful. It's one of those other stepchild that just kind of gets forgotten right until it's driving you nuts because it's ringing or you can't hear or it's plugged. We know that it's so important for sound conduction, and that is the outer ear, the middle ear. We know it's important with neural transmission of sound, the cochlea and the acoustic nerve or the auditory nerve. And then it also helps with balance. Remember when we talked about vertigo in neuro, that vestibular system that's located within there. My goodness, those canals that can get clogged with the crystals and make you feel like your world's spinning. So the ear is very important, and you're going to treat a lot of different type of ear complaints in primary care. One of the things you're going to talk to patients about is hearing loss, all right? The spouse of an older adult reports that the patient's hearing is declining. After performing the exam, the NP suspects presbycusis. What should the NP do next? She says, George, turn the TV down, turn the TV down, all the time, because his hearing's just getting worse. What do you do next? The best answer here is refer to audiology for audiometry. Now, and that might be different based on where you are. Here we go to audiology, they do audiometry. Anytime a patient's complaining of hearing loss, they should really have formal hearing testing. Now, we do, and you guys all know about the instances where, you know what, it was just wax and you're going to get that out. So 4 could be correct, but look, in the stem it says the NP suspects presbycusis. We know this is a sensorineural hearing loss. and we should get them to audiology. So the best answer is number one. Now, how are you screening patients? The USTSPS task force says there's no like universal screening. Not everyone should be screening. I feel that hearing is so important in our kids and our older adults. And so if there's any, it's not universal screening, but you should be asking about it, especially if there's any sort of concerns that maybe it's an issue. You can do the whisper test. That's where you stand behind them, tell them, say some numbers or have them do something, raise your hand, something, and then you do the other side, and you're checking to see if they can even hear you. All right. But once again, in bright orange, anyone with general complaint of hearing loss, send them to our friends. They are great. All right. Now, in primary care, we are going to see and diagnose and treat two different kinds of hearing loss, conductive and hearing. And we're going to go through how you figure that out, when to refer, who to refer, where. But you've got to know that there's different types. There's conductive hearing, sensorineural hearing, and sometimes mixed. Depending on the severity, it's just going to depend on where you send them, when and how, and what you're going to do. So let's go through all of these. So conductive. Think about the sound waves are not getting in. It's obstruction. There's something obstructing the sound. And most often, especially in our elderly patients, what is it? Big old ball of wax. Now you can see this in kids. When my little boy was little, I swore he had a bug in his ear. And we made an appointment. We go in, they irrigate, and guess what? Big old nasty thing of wax. And I thought it was a bug. But anyway, you'll see this in your elderly patients too. I hated cleaning out ears. I liked the eyes. Let me fluorescein stain. I let Alicia do all the ear stuff. That was my nurse, and she loved the ears. But anyway, it can be that. Maybe they left, a headphone piece in it. It could also be infection in the external canal, swelling, inflammation that's causing obstruction. It's usually more acute. Chronic causes are less common unless it is like a chronic infection issue, fungal infection, something like that. Now, sensorineural hearing loss. The most common in what you're going to see is the presbycusis, all right? Age-related, noise exposure, genetic factors, and it's that hearing loss. They can't hear my voice, so I have to go down. Tinnitus, crickets, ringing. But look, and we've mentioned many of these even in our neuro lecture. There's a bunch of other causes. All of these other things, guess what? You're pretty much going to get them to ENT, right? For further workup or at least audiology. When you're looking at sensorineural, you're worried about the nerve or the cochlear problem. It's not an obstructive problem, all right? It's just like the name implies. So what is the most important reason to optimize hearing in an older adult? It's patients who can't hear. They're more likely to become injured in their ADLs. Hearing loss reduces ability to perform tasks independently. Older adults who cannot hear are not legally able to drive, or hearing can lead to isolation, cognitive decline, understimulation. The best answer here is four. My dad cannot hear a thing, and he refused to wear his hearing aids forever and ever and ever, and he's almost to that point where it's a little too late. But it is so true, and I've seen it in him. So much isolation, and even with me, it's hard for me sometimes. I'm like, I'm not even gonna say what I want to say because he's not gonna hear me. And this is why I feel so passionate about making sure you're sending patients to audiology, screening them and testing them. Just like a little baby or a 2-year-old, we check our newborns, right? And if you think a 2-year-old's having problems, we know that's going to impact their development. It's the same with our elderly patients too. So make sure you're assessing that and referring appropriately. These other ones, not necessarily more likely to get injured, or they can't do their ADLs. My dad does everything. He can't hear a thing. And then legally to drive, that's not correct. So the best answer here is 4. Now, your job is to figure out what type of hearing loss is this, and you're going to ask a lot of questions, just like we've said in every single lecture. How did it start? Is it both ears or one ear? That's huge. Do you have vertigo, vestibular symptoms? You're going to look in that ear. If there's something in there or they have wax, you're going to get it out. But If you're like, oh, I don't really see a known cause, then first, the next thing you have to do is you have to determine, is this conductive or sensorineural? Sensorineural, whatever. Now, there's only one true, really hearing loss auditory emergency, and this is an abrupt onset, unilateral, okay, sensorineural hearing loss. And this is an emergency, and they need to go to ENT. They might get some high dose steroids to preserve that hearing, but that's only one. So how are you gonna know? How are you gonna know? Because you gotta go. If they say it's that abrupt onset, you gotta figure it out. Is it conductive or sensorineural? And you're gonna use our friend, the Weber and Renee. All right. So Weber, tuning fork, forehead, top of the head. Where do they hear the sound? Does it lateralize to the right or to the left? Does it go to the good ear or the bad ear? And you're going to want to star these slides and come back because this is kind of crazy when we're explaining it. Conductive loss is going to be louder in the affected ear. Sensorineural loss is louder in the unaffected ear. So that is helping you figure out lateralization, okay? After that, then you're going to do the Renee. You put it on their mastoid bone. You hold it here, and they're getting conduction from the bone. So you let it, and you ask them, whenever you stop hearing it, you can't hear it anymore, you're going to move it in front of the ear, all right? And then you're going to tell me when you can't hear it. In the Renee test, a normal Renee test is a positive test. Normal is positive. That means air is louder than bone conduction, okay? An abnormal test is bone is louder than air conduction, okay? You're trying to figure out, am I worried about conductive or sensorineural loss? Because that abrupt sensorineural hearing loss is the only emergent hearing loss that we really need to say, oh, we got to get it treated abruptly. Now, I think Dr. Lindsay put this together because she has like all the knowledge and degrees in audiology. So, or hearing, I don't know, some sort of up here, ear sciences. You're gonna do your unilateral hearing loss. You're gonna do Weber. This tells you exactly step by step. Does it lateralize to the bad or the good ear? If it lateralizes to the good ear, sensorineural hearing loss. If it lateralizes to the bad ear, then you're going to do Renee and do the bone conduction. If bone conduction is louder than air, then it's conductive, okay? I know that's a lot. Look at it. There's some good YouTube videos. This is another time when it might help seeing it done. But those are the tests. They may ask you about those on the exam. Now let's do some name that diagnosis. The patient presents with tragal tenderness, narrow, inflamed ear canal. What are you worried about? Otitis externa all day, every day. Most common is what? Pseudo and staph. And what do we treat it with? Remember that one confusing slide that says staph and then not staph? Yes, you know, ofloxacin, ciprofloxacin. Okay. Presents with severe ear pain, otorrhea, hearing loss, tenderness in the mastoid process. I'm not happy with that. Mastoiditis. And this is a referral. Why? That infection can get deep in, can cause meningitis. You can get cellulitis, osteomyelitis. Not a good thing. Presents with ear pain, mild hearing loss, bulging of the tympanic membrane, may report a recent URI. And this is textbook Hallmark. You will treat a ton of this. What is it? AOM, right? There's a lot more information in the pediatric supplemental material on this, but remember, you really want to see bulging. There may be an effusion, maybe a mucoid effusion, there may not be. You're looking for rupture of tympanic membrane. I'm thinking about this right now. So while I'm thinking about it, I'm going to say it. If you ever clean those ears out with irrigation and or with a curette, please make sure you document intact TM after. You always want to look again. Did I get the wax out? Is the TM intact? So sometimes with otitis media, you might have a rupture of the TM and you might see the purulent or bloody drainage coming out. But that is textbook for otitis media. We've talked about treatment through antibiotics, and there's more in pediatrics too. All right, which of the following are indications for cerumen removal? We've already talked about hearing loss. Yes. An earache? Yeah, if it's bothering the patient. Itchiness? Absolutely. And then we've talked about cognitive impairment. Maybe it's just that they can't hear, or maybe they're not able to tell us what's going on, but we see it. Now, orange thick cerumen. This one is not a clear indication. That could just be some thick cerumen that may not be obstructing. That one's kind of, but the best answers 1, 2, 3, and 4. Now, we talked about this eustachian tube dysfunction with our sinusitis, right? But where is the eustachian tube? What does it do? We know it runs from our nose to our ear, right? It helps with equalizing the pressure. So when you fly, or when you're going up a big pass or down and you get the popping and the pressure, think about your eustachian tube, right? We can see this with effusions, and sometimes it inhibits appropriate drainage. Patients will say pressure, popping, that's what they're talking about. Now, you're going to treat the underlying cause. Most often, it's usually related to like an allergy or a rhinosinusitis. And the best way to treat this, we already talked about the intranasal steroids, possibly maybe a Sudafed, maybe an antihistamine. But you will see that as well. Okay, let's move on to the eyes. The eyes. See, I don't like the ears as much. I like the eyes. They're fascinating to me. All right, so when you have red eyes, it can be caused from a million things, right? Is it infection? Is it glaucoma? Is there trauma? Is it something maybe not quite as major, like conjunctivitis, blepharitis? Blepharitis, don't look that up. People misdiagnose that all the time, but it can be allergic or squamous. But if it's just the eyelid that's swelling and itchy and flaky, don't diagnose conjunctivitis, okay? Look that up and make sure you're doing that correctly. We're going to talk about a lot of these, but you will see patients coming in with complaints of red eye all the time. So red eye, I want you to think red flag. There are certain times that it's just like, ooh, you got to be careful. You want to get sued? Miss something with the eyes and cause someone to get loss of vision. That doesn't go over well. All right. So now with the red eye, red flags, if there is a change in vision, is that concerning? Absolutely. Absolutely. All right. Change in vision is a red flag. They need further evaluation. Foreign body sensation with an inability to keep the eye open? Yes, you're worried about a corneal abrasion. What about photophobia? They can't even look because it's, oh man, the light is so bright. Yes. Now, a foreign body sensation, not necessarily. Sometimes that can just be some conjunctivitis, allergies. Now, if they told you that there was a foreign body or something, then absolutely. But anytime you see these other change of vision, foreign body, photophobia, you really need to be worried about maybe corneal abrasion or something else going on. And we'll do some patients here so you can get it. All right. So which of these patients need a referral? Nasal congestion, fatigue, and bilateral mucoid discharge. No, not necessarily. You're probably thinking conjunctivitis, and just like our URIs, most of the time it's viral. Warm compress, some lubricating drops. Now, if it's unilateral, severe, going on and on and on, they've had known pink eye exposure for bacterial conjunctivitis, maybe, but they definitely don't need a referral. What about sudden, severe pain, redness, blurry vision? That's all the red flags, right? So yes, and you're thinking maybe acute angle closure glaucoma. Sometimes you'll also see a clouding of the cornea on that, okay? Presence of flashers, floaters, or curtain vision loss. That is not good. Retinal detachment is one of your concerns, and man, that is horrible. Thank goodness they have really come a long way with retinal reattachment surgeries, but that patient's going to have to lay on their stomach for many, many days, and that's not fun. But that would definitely require a referral to ophthalmology. What about painless, bright red pool of blood on the surface of the eye that appeared after coughing? No, no. This is what? What is this? Subconjunctival hemorrhage, and you'll see this. It can be even a tiny, minor trauma. They kind of got hit in the eye or pressure in the eye. One thing you do want to ask about though, hey, what's your blood pressure? Because it may be an undiagnosed or uncontrolled blood pressure can also do that. If you ever have circumferential hemorrhage of the conjunctiva, that's also a red flag. But mostly just a spot, a simple subconjunctival hemorrhage, no, doesn't need a referral. The body's going to reabsorb that in 1 to 2 weeks. They might want some lubricating drops. All right. Macular degeneration, this is a sad, sad condition, that loss of central vision, okay? And they might see curvy or straight lines. The thing is their peripheral vision and their color vision, it's normally intact. But it progresses progressless. 80% dry, 20% is wet. The wet is worse and leads to progressive blindness. We can do supplements and they can do injections and really good sun protection, UVA, UVB. But central vision loss, you're thinking macular degeneration. All right, now retinopathy. Oh, retinopathy, you need to know about this for your test and for your clinical practice, okay? We talked about it in neuro when we were talking about papilledema. You've got to be able to do a fundoscopic exam. So let's give you a couple of tips to hopefully make sure that you are successful in doing this. Best way, turn the lights off, get that pupil dilated. You're gonna get the ophthalmoscope. You're going to set it to your eyes. If you wear glasses, take them off. You're gonna set it and you're gonna dial the dial on the side until you can see. And you're like, oh, okay, that's not blurry. Then you're gonna put your hand on their forehead. You've got the ophthalmoscope here, right hand, right eye. You put it here. Okay, you come in on his side, you elicit the red reflex. We all know how to do that. When you get the red reflex, stop. Okay, stop. And then you're gonna slowly, slowly, slowly increase, looking for the full moon, the full moon, the full moon. And you're gonna see it. And it'll look, similar to that. You might see it for just a second and it's gone. But as you practice, just like Jennifer said, you're gonna see it more and more. The reason this is important is because we are looking for many of these signs. Our patients that are diabetic and hypertension, which is a lot of them, right? We might see a flame hemorrhage that looks like a little flame. We might see cotton wool spots that look like a little cotton wool. We might see AV nicking. So if you see those, man, we're worried about a diabetic or hypertensive retinopathy. Now, of course, these patients should be getting that true dilated ophthalmology exam, but you need to be looking for that too. So keep practicing, and hopefully you'll start seeing that full moon and you'll become more and more comfortable with doing these exams. All right? You did it. Oh, you did it. Look, we made it. 2 long days, but it's done. All right, here's your exam checklist, and we are ready for your questions. What are your burning questions for the last 2 days? How can we help you ease some anxiety or answer anything that you have?
I feel like we need some sound effects or something.
Yes, like the fireworks.
Fireworks. I know, you guys made it, so yay!